All right. Well, it's great to have everyone be here today, and sorry for the rescheduling. I'll probably try to make some adjustments from here going forward now that the organizing committee for the ACVNU, those meetings are now hopefully set in stone. We'll just make sure that this session occurs on the opposite week so that we'll be able to get more people who can attend. Um, but the last session we had going back a couple months ago now, we were talking about renal sodium handling. So now we're going to kind of look at the flip side of that, where we're going to be talking about when the sodium handling might become abnormal and how that might manifest itself in reduction of urine output. And so the two articles that we're going to go through, the first is this a bit old, and we'll kind of talk about how it's a bit outdated, just review of Oliguria, and then this acute renal success manuscript, which I absolutely love. Why don't we talk first about the New England Journal of Medicine article, the review on acute oliguria. Why don't we just open up? Does anybody have any questions or any comments that they have about that article before we kind of start going through it piece by piece? All right, I guess not. Um, so, what we can just go through some of the notes that I took on it. So they defined oliguria as less than 400 mils of urine per day, and I've seen in better and human manuscripts probably 25 to 35 different definitions of what oliguria is and what anuria is, and we probably don't have that many in veterinary medicine, but we don't have a clearly defined number, although there are now urine output guidelines on the IRIS acute kidney injury grading paradigm. So we do have that, which I suspect everyone will agree upon. But even those are somewhat arbitrarily established. But for a human producing less than 400 mils of urine per day, presuming that they are a 70 kg person, that's about a quarter mil per kg per hour. When I did the math, it was 0.23 mils per kg per hour, which I I think of oliguria as probably being more than that personally, because I think of it when the kidneys aren't working, you either have the polyuric state, you have a lack of polyuria, and you have no urine that's produced. So we don't really have a state where you have acute kidney injury and urine production is should be exactly normal. So if they make more than 2 mils per kg per hour, then I would presume that that's a polyuric state. If they're making less than probably a quarter mil per kg per hour, what they defined as acute oliguria, I would probably call that anuria. And I wouldn't define anuria as just being zero because, as we discussed in one of our previous sessions, you will have some diffusion of fluid across the urothelium. And that, what we call bladder sweat, can accumulate and can cause the appearance of urine output, even though it really isn't urine. So I personally use a cutoff of about a quarter mil per kg per hour as anuria. Anywhere between a quarter and 2 mils per kg per hour, I tend to think of as being a relative oliguria, that they're not making a they're certainly not polyuric at that standpoint, but the cutoffs again are somewhat arbitrary. Even the iris cutoffs are not based upon data to say a urine output of below this amount has a worse outcome than a urine output above that account. It's just kind of arbitrary guidelines. But that is what this paper had included as their definition, but again, there's many different definitions that have been put forth from human different papers. They do mention that when patients develop oliguria outside the hospital, it has different etiologies and a better prognosis than in hospital and acquired oliguria. And I don't know if I totally agree that we see that. I think a lot of our patients may come in with an acute kidney injury that might be oliguric from the beginning. Maybe we didn't start characterizing their urine output, so maybe we just don't know. And some of those patients certainly could be made worse with fluid therapy and our interventions and might acquire oliguria while they're in hospital. And I think those patients are certainly those that have a worse prognosis overall. But we tend not to see as much oliguria just coming in right from the streets. And certainly some patients, like your lepto patients, might, your ureteral obstructions, they might, but your intrinsic AKIs are probably not quite as commonly going to see that. And so even amongst the IRIS staging guidelines for AKI, I think most people would characterize and or grade the AKI according to creatinine rather than urine output. And that's even true for humans. Looking at the KDIGO and the KDOQI guidelines on acute kidney injury in people, there are cutoffs for urine output or creatinine, but it's almost always deferred to the creatinine being the metric that's followed most closely. Okay, so then they get into some causes of oliguria, and again, we're not gonna read the articles together, but I think just the things that have changed. So this paper was from 1998, so it's quite a while ago. We're talking about 30 years ago. And they talked about using invasive monitoring and CVPs and capillary wedge pressures for volume management. And I think largely that practice has been minimized in human medicine. I'm sure it certainly still plays a role in some critical patients, but in terms of goal-oriented therapy for stabilizing and maintaining hemodynamic and cardiovascular output in people, those are not the strongest indicators for how well a person is perfused. I think it's pretty uncommon that we turn to using those in veterinary medicine these days. It's probably institution dependent. When I was a student at Penn, I think they were checking and monitoring CVPs on pretty much every critically ill patient. That wasn't the trend when I was back as faculty, and I think it's probably still not a very common practice that is done now. But it is certainly something that could be there to help us with our volume and perfusion assessment, but is not nearly as clear cut as we wish it to be. They talk a little bit about looking at post-renal causes and ideally doing an ultrasound, and that's still fairly true. A CT is often going to be done in combination with an ultrasound in people. We're still looking at ultrasound most commonly rather than CT scans for diagnosing obstruction in our patients. And the thing that I highlighted is that while most cases should cause pilectasia and ureteral obstruction in front of the obstructive lesion, there are a number of conditions that will fail to produce that dilation. And so the big ones in people are malignancy, if the patient's dehydrated, there's retroperitoneal fibrosis, or if there's just not enough time that's gone by to see the obstruction. And I think that those things are very true for our patients as well. I would throw out another theory that some of these cats with significant chronic kidney disease and tubulointerstitial fibrosis, maybe some of those cats have a less capability to become distended in terms of when they have a ureteral obstruction. And it's been shown 23%, I think it's 23% of cats with nephroureteral obstructions had a renal pelvis that was less than 4 millimeters in diameter. So to me, this was just a good reminder that a failure to see hydronephrosis in no way excludes it from being an obstructive lesion. And if you see your patient having minimal urine that's being produced, but you're having progressive pilectasia, that's a slam dunk that there has to be an obstructive lesion that's there. That you shouldn't be, I mean, that's showing you post nephron, there's fluid accumulation, but it's not making it to the litter box or to the outside. So there has to be some type of blockage that's there. So just a good reminder overall for that. Next, they get into looking at some urinary sediment. And again, I think this has changed some. And I think looking at these indices are not as strong indicators of AKI and urine production as what they turned out to be. Even calculating fractional excretion of sodium has a lot of caveats and limitations. But they discuss in pre-renal AKI, you should see these hyaline and coarse granular casts. And then with intrinsic AKI, 80% of patients will have brown granular casts with tubular epithelial cells. And they have this picture of these muddy casts here, which is beautiful, but we don't see that. That we do not see casts in 80% of our patients. When we do, they're usually granular casts. I can't say that I've seen muddy brown casts like this. I'm struggling to remember the last one that I've seen. Part of that might be the timeline it takes for us to get urine and have it analyzed. Now, doing it in-house obviously can make things a lot faster. Looking at your urine yourself is always recommended. We make a slide and look at the urine that we submit on every one of our patients. We take a look at it ourselves because, number one, we want to see what it looks like. Number two, it's a more timely thing. Even though we get our urine sediments back typically the same day and it's run in-house, remember that these casts are going to dissolve and they're going to go away and we're going to lose them. Jess, how often do you see muddy brown casts in urine? I can't say that I've personally.
Are you able to hear me okay?
Yeah, I can.
Okay. I would say maybe once every month. I probably get a case like this, maybe once every couple of months. It's not super often, but of course, remember that I'm getting cases from all over the place. So that might be a little bit of a high estimate. It's not real often. And as you can imagine, given that our samples are coming in, being mailed into us, it's possible that there maybe were more. And what I actually usually tend to see is, and if they've described casts in the past, I'll get a background of just sort of the muddy brown debris. And I can't really call that casts, but I sometimes suspect that that's what they were. And as JD said, the casts dissolve so fast, and it can also be partly dependent on the pH of the urine. But it's always really great to, again, look at them within an hour of collection, but they will fall apart so fast. I think, white blood cells will dissolve within, and usually you'll have like half of what was present within an hour of collection, and casts, I feel like they fall apart even faster than that. So I'm always impressed when I get a sample that still has casts in them. I'm always thinking, how many were there before I saw this, or what is it that's different about this urine than other urines that they've stayed stabilized? So
Right. Exactly. Oh man, if I would have seen this right when it came out of the animal, oh, it would have been so gross
exactly.
and awesome at the same
I
time.
know when I get ones like that where there's just casts everywhere, I'm like, what the heck did this look like when it first came out?
Yeah,
So yeah.
exactly. Yeah, I agree. And I will certainly make the plug and that every nephrologist should look at their own urine. It is essential to having a better understanding of what's happening with your patient, that when we have great clinical pathologists that we can work with, it's an amazing asset, but we don't always have it. And they might not be available. You just need to get comfortable looking at urine. And you can do that with literally a single drop on a slide. That's not going to be the best sample. It's not going to have the highest yield, but it can be as easy as just a drop. And for looking for UTIs, it's so easy you're going to find bacteria in a drop. It's a very simple thing. If you have a little bit extra that you can spin down on your own and take a look at it, it will never be a disservice to your patient for you to look at it in addition. Even if you're not confident in what you're seeing, great. Well, practice. What did you see? What did the
Or
pathology see?
photograph
Compare
it.
that. Yeah,
Or yeah,
exactly.
take a screenshot of it or photograph it with your iPhone and send it
Yeah,
on to somebody. We do that all the time.
right. I think it's probably a couple of years ago. I think I sent Jess and Mary a photo of something that kind of looked like a red cell cast that we just rarely see in veterinary medicine. Even when all of us were looking at this photo and it was my phone through the microscope, we were all like, maybe, maybe.
Yeah,
It's
we
just
so infrequently see those. They're exciting when we do. I think even Mary sent me
right.
one a few weeks ago and she was like, I think this is. And I was like, I think it is too. But we so infrequently see them, at least in our veterinary patients. I guess they see them a lot more in people.
Yeah, it blows my mind that they can see so much. And I don't know if it's just the tubular epithelium loves to slough off in people, or maybe it's the pH or the specific gravity in dogs and cats that makes these
Yeah.
casts just not stick together, but we just don't seem to have the same sensitivity as what's been reported in people. Because I would definitely say that 80% of our patients with AKI don't have brown casts
Right.
and tubular epithelial cells in their urine.
I had one case just a few weeks ago that I was convinced had like tubular epithelial or at least epithelial cell casts. And I was like, oh my God, this is gorgeous. And I took so many photos of it because I almost never see those where they're
Right.
intact.
Yeah.
All right, I'll
Yeah.
shut up now.
No, great insight for sure. So it's a plug to check urine for sure on all of your patients. The table here, the principal causes of acute oliguria, the pre-renal uh, causes, volume depletion is the big one. Heart failure is the other one. Medications that could cause essentially abnormal renal perfusion is another thing. I can't say that I'm not the one who's managing these patients. An acute patient comes in with bad acute hemorrhagic diarrhea syndrome where they've lost a lot of fluid. I do expect them to have decreased urine output, but I would not think that I would classify that patient as being oliguric. That patient's not going to be one who's going to get a urinary catheter when they come in right away. We're not going to have measurements. So to me, I think having patients who have effective circulating volume deficits coming in with oliguria is not a very common scenario because we recognize they're dry and we start them on fluids and we see that they're making urine. And so I don't think that that's nearly as common of a scenario. I think that we're often looking at our renal injuries and post-renal injuries as being the main causes. And post-renal causes are a little bit easier to exclude. You image the urinary tract, usually ultrasound, maybe a CT. You might consider doing a contrast study like an antegrade pyelogram, and you are trying to diagnose some obstruction. It could be urethral, it could be within the bladder. More often than not, we're talking about nephroureteral obstructions in cats and then less common in dogs, but we see it in both. So you hydrate the patient, you exclude all the post-renal causes, then you're left with your renal causes. And they talk here about it being interstitial nephritis, which we have seen on biopsy, acute tubular necrosis, which is really just a pathologic description of acute kidney injury, which is secondary to, they list pretty much everything that can cause AKI. Vasculitis, think we see really uncommonly. Glomerulonephritis, absolutely, we see that cause acute kidney injury, and those patients can absolutely be oliguric as well too. They're typically going to be quite hypoproteinemic. They're proteinuric, and then they really don't tolerate fluids when you put them on a crystalloid as well. So there's a lot of overlap for what diseases that we are looking at, and what we're managing in our day-to-day clinics. Looking at these urine indices, the urine sodium, the fractional excretion of sodium, and the ratio of creatinine and osmolarity are not things that I think are commonly performed. The fractional excretion of sodium has really not been shown to be a great predictor. This 1% cutoff was used, but newer studies, even in the last year or two, have shown that its utility is not that great. Urinary sodium is similarly not perfect for animals who have quite different diets. And the other limitation is that for a lot of these tests, you just might not have the availability to do them. So if I want to do a urine chemistry or urine osmolality, I have to get that sample and I have to send it out to a different lab to run it. I can't run these in-house. So a lot of these tests we just haven't really validated in veterinary medicine, partly because it might not be available for all clinicians to run. Maybe there just hasn't been the interest, but I think there's a lot of opportunity to look at these further, but we've not really had good validation in naturally occurring acute kidney injury in our patients. So looking at urine is not something, looking at a urine chemistry is not something I routinely do as part of my management of the patient with AKI unless I'm really trying to work up some electrolyte abnormalities that they might have. So that's there, but it's again not something that I feel super strongly about. And then kind of the last thing they put here, preventing intrinsic AKI, just really trying to keep them hydrated and preserve their intravascular volume. That's no big surprise there. Avoiding nephrotoxic drugs, not a surprise. And then they talk about the complications, which essentially any organ can become abnormal. And then the last thing I wanted to mention is this section that they talk about for the management of oliguria. And in that, it's just interesting to show, again, this paper is from 30 years ago, that they're talking about some, even at that point, some experimental studies that have shown some promise, but drugs that have, once you put them into clinical medicine, have not been helpful. And they discuss one, this ineritide, which is, I think, an ANP agonist, and it had no benefit when they looked at it in a larger trial. It actually had to be discontinued. The potential benefits of converting the an oliguric patient to become non-oliguric might help keep them off dialysis, might allow them to tolerate more fluids, but at the same time, the effect on outcome and prognosis has not been well established, and that continues to this day. That even the more recent literature looking at the effect of converting a patient from oligonuria to a uric state does not necessarily mean you've done anything to change their GFR. They just might be peeing. So in states like, in hospitals like us, where we have dialysis, we don't really spend a lot of time trying to convert them because their GFR might still be in the toilet despite the fact that they're peeing, and we still need to dialyze them. So for us, we really will do that if we're just really considering patients who dialysis is just not an option. The owners can't afford it, then we might consider trying to convert them, and a loop diuretic will often start with that. They talk about loop diuretics, and if they don't work, they could be potentially toxic, and ototoxicity can be seen. They talk about dopamine here, which has been no longer recommended in the KDIGO guidelines. That has changed a little bit in the sense that dopamine has been replaced with phenoldiazepam, a more selective DA1 agonist, and that has been thought to be more effective. And in small studies in people, this is post-cardiothoracic surgery, phenoldipan has been shown to increase urine output and decrease the incidence of postoperative AKI, but in all patients, it hasn't been shown to be effective. There have been some studies of phenoldipan in veterinary medicine. We did a prospective study showing phenoldipan increased fractional excretion of sodium, and that was likely how it caused increased urine output. But we also saw that it increased GFR in healthy dogs. There have been, I think, one retrospective, maybe one prospective study in AKI in animals, and both failed to show an improvement in survival. I don't use phenoldipan. It's expensive. I'd rather would dialyze them because I'm not convinced that it's going to work. But even in the human guidelines, phenoldipan is not still strongly recommended as an option. So despite this paper being 30 years ago, we don't have a lot of new options. Once they're not starting to make urine on their own, if they don't respond to Lasix, they didn't even include mannitol here. And talking to a lot of human nephrologists, they don't even touch mannitol as trying to convert them from an anuric state. Once those medications don't work, then you have to dialyze them. And we're still in that state for people, and we're still in that state for animals. And unfortunately, dialysis is just not an option for everybody. And then at the very end, they talk about some things that might have promise: ANP, antioxidants, arginine, glycine, aspartic acid peptides, things that you probably have never heard of, which means that they have failed to be effective. So at that point, 30 years ago, those were some of the new up-and-coming promising agents that have kind of failed. And it's not surprising to think why these interventions are going to fail. The kidneys are busted. They're not working well, so they're probably not going to respond well to medication that needs to interact with the kidney to have its effect. No big surprise there. Okay, those were the big take-homes I had from that New England Journal of Medicine. I think the other paper is more interesting, and I'd love to get into that more. Are there any questions or comments about the acute oliguria review before we jump to that one? All right. So let's pull up acute renal success. I love this paper. The unexpected logic of oliguria in AKI. So this manuscript I really liked because for me, it really kind of flipped things for me, because I had heard and I had read that oliguric and anuric acute kidney injury represents a more severe injury. And this really suggests the opposite. And I like all of the physiology that was in this and the concepts that were brought forward. So I'm glad we got a chance to read it together. So let's just start. Were there any aspects of the article that people didn't understand, that there were questions about, before we start going into my take on things?
We're a
All right.
quiet group, JD.
I'm, I'm used to it. I feel bad. You guys hear me talk
We're
all the time. I'm
we're a
sure that's
small group too today. I guess a lot of people are out.
yeah, I think a lot of people are taking their last vacations before the end of summer. Rightfully so. That's all
Yeah,
right.
well, and I think today's also like, at least for the pathology side, today's like the last day of their board exam.
Ooh,
So a bunch of people are out for that too.
they should be here instead. That's all right. They'll just have to watch this video instead. Okay, well, let's get into this manuscript. They lead it off by saying little thought has been given to the concept that the kidney may be acting appropriately in making a small volume of urine, and that might be necessary as a functional adaptation to protect the patient from a graver danger. It's like captivating. I love it. So they get into the physiology, and I had to highlight in different colors just some of the great quotes from this paper. The kidney has a reputation for sensible behavior. Fantastic. I love it. So it talks about the fact that in a normal person, the entire plasma volume is filtered and reabsorbed twice per hour. That is a ton of volume that you're processing. So I went back and I looked at some of the GFR rates in dogs and cats, and most patients are somewhere around 2 mils per kg per minute for GFR. And it can be higher. It can be up to 3 or even up to 5 mils per kg per hour. But if we just presume 2 mils per kg per hour is normal, which it is in both dogs and cats, and we make the presumption that your total blood volume is, we'll say, uh, 90 mils per kg, and we're going to presume a hematocrit of 40%. So that means your plasma volume is 60% of the 90 mils per kg. So that's 54 mils per kg. That's your plasma volume. And if your normal GFR is 2 mils per kg per minute, or 120 mils per kg per hour, and your plasma volume is 54 mils per kg, then just like in people, our dogs and cats are filtering and reabsorbing their entire plasma volume at least twice per hour. And if their GFR is really 4 mils per kg per minute, then they're processing their blood volume 4 times per hour. So this is true in dogs and cats as well. And that's based upon experimentally calculated GFR measurements in dogs and cats. So that is a lot. There's a lot of redundancy. They note that this is a evolutionary adaptation that had developed when we were all saltwater inhabiting fish. And if you haven't read From Fish to Philosopher by Homer Smith, I strongly recommend it. It is a great book to talk about the evolution of the kidney, and it's really fun. So there's definitely a throwback to that as well too. So we have filtration of our plasma volume over and over and over again, and we have to reabsorb it. And in fact, if we don't reabsorb it well, we're going to have significant problems. What is different here, and so in figure 1, it starts by just a normal capillary bed. And a normal capillary bed, even think of this like your vasorecta capillaries. On the arterial side of that capillary bed, according to Starling's forces, you'll have the predominant force being fluid leaving the capillary bed, entering the interstitium because the hydrostatic pressure is high. The oncotic pressure is about the same. So it's driven by the capillary hydrostatic pressure. But as you lose that fluid, as you go through your capillary bed, that hydrostatic pressure is reduced. That blood also becomes more concentrated because you've lost some of that plasma water. So by the time you get to the venous side, you lost the hydrostatic pressure, and because it's more concentrated, the oncotic pressure is gradient, and so it favors reabsorption. And that's exactly what happens in your vasorecta capillaries. That's post glomerulus. Your efferent arteriole becomes your vasorecta capillaries. So that blood is concentrated, it has a low pressure, and it can absorb all those solutes that are coming from the basolateral side of your tubule. Now, what's different in the nephron is you have all of these tubular epithelial cells, ranging from your proximal tubule, your loop, your distal tubule. Everything is in there in between, and that allows for the kidney to be selective for all of these additional solutes, either reabsorption, active secretion, lots of different ways that the kidney can manifest it. So it's a different system overall. GFR, the energy, yeah.
Oh, sorry. I don't know if you're actually, I can't see the page numbers yet. Dr. Ha had a question in the chat.
Oh, sure.
But has the microphone off, so I just wanted to note that.
Yeah, thank you so much. So they say renin activity increases when the tubular fluid sodium chloride concentration is increased. Okay, yes. Okay, we'll get to this very, very shortly because they talk about both of these aspects for sure. Okay, so this brings up, and we're going to lead right into that, this concept of tubuloglomerular balance. And that is where, so this was always a little bit confusing to me. The kidney has three major physiologic properties. It has autoregulation. Autoregulation is the ability of the afferent and the efferent arterioles to constrict to maintain perfusion. And it can do that between mean arterial pressures as low as 60 and about as high as 160. So autoregulation is number one. Number two, glomerular tubular balance. And that's where, as your GFR changes, the function of the tubule will change in relative proportions. So if your GFR drops by half, your proximal tubule will still perform reabsorption of 2/3 of whatever is going to come down the pipe. It's not an absolute quantity, it's a relative proportion. So that's glomerular tubular balance. They call it tubuloglomerular balance. I call it the third, tubuloglomerular feedback. TG feedback, that's the third. Autoregulation, glomerular tubular balance, and TG feedback, tubular glomerular feedback. And this is the process we're going to dig into. So tubular glomerular feedback is how the nephron can sense filtration and then adjust its own filtration, adjust its own GFR. And we talk about this all the time when we talk about the RAS system. And if we go down to figure number 2, this is really the way that nephrons are, that they look. We commonly draw like the glomerulus off to one side, proximal tubule, loop, distal, and then the collecting duct. But in actuality, the distal tubule comes back around and it sits right between the afferent and the efferent arterioles. I thought maybe they had another image, but they don't. And that specialized area is the macula densa. And the macula densa is going to respond to the sodium and chloride concentration within the tubular lumen. And in fact, between the two, it's not sodium, but it's actually the chloride concentration. And we think that this site is what is involved when we have decreased GFR. And when we have decreased GFR and there's less filtration, there's less quantity of solutes, we're going to have still 2/3 of that solute reabsorbed by the proximal tubule, another 15% reabsorbed by the loop of Henle. And so what goes to the distal tubule is going to have a lower absolute concentration of chloride. That triggers the macula densa to release renin systemically. And that activates the RAS. Renin cleaves angiotensinogen into Ang1. Ang1 becomes Ang2 because of ACE. Ang2 pulls sodium and water out of the proximal tubule. This stimulates aldo release. Aldo pulls sodium and water out of the distal tubule. And so that's what helps restore our hydration. It takes that fluid, puts it back into circulation, but the patient is dependent upon thirst to actually get their volume to be expanded. So here we're talking about the opposite. So I think that's the concept we all feel really comfortable with. The RAS system is activated when we have decreased GFR. The mechanism of how that decreased GFR is sensed is the juxtaglomerular cells of the macula densa sensing the low chloride concentration within the tubular loop. So now we get into the fun stuff in the last 10 minutes of today's session of what happens when the proximal tubule doesn't work well. What happens when we have a failure? So instead of reabsorbing those 2/3 of all the sodium chloride molecules that are present in the proximal tubule, let's say the proximal tubule doesn't work well and we have it's only doing its job 50% of what it should be. We're going to have massive loss of sodium and chloride and thereby water going through that nephron. And that will lead us to having fatal volume depletion within hours. So, what will kill us first? Volume depletion or azotemia? We can survive with being azotemic and uremic likely longer than the couple hours it's going to take us to become volume depleted and dying. So this mechanism, which I don't think I learned in vet school, I might have slept through the classes. There's a reasonably good chance of that, but I don't think it ever came up. But this is an important aspect of physiology that here, if we have too much chloride, now the macula densa senses that, and it still will stimulate the release of renin. But the difference here is that the renin will be present locally. And they mention somewhere that locally all components of the RAS system exist within the macula densa. I thought I might have highlighted it in different color, but essentially everything exists locally. Yeah, the JG apparatus is supplied with all the necessary components to manufacture and degrade angiotensin II. So what happens when we have decreased chloride is that local production of renin will only cause local production of Ang2, and we'll get afferent vasoconstriction, and we decrease the GFR of that nephron. So the nephron is saying, in the anthropomorphic way that I like to ascribe to the kidneys, we are losing way too much volume. We are going to die. I'm going to shut myself off. So I'm not going to filter. I'm not going to contribute to GFR. We're going to become azotemic, but we'll be able to survive with that longer than we will by being severely volume depleted. And so it's an evolutionary adaptation. And these researchers say, well, that is actually the appropriate response to when the kidneys are busted, when the proximal tubule is not working well, because you have acute kidney injury and you have proximal tubular cell death because of lepto living there or any toxin. And remember that proximal tubule exists in the outer portion of that outer medullary cortical junction. Under normal circumstances, that region of the kidney is nearly hypoxic. There is only a 15 millimeter of mercury oxygen gradient that exists there. So any times that we have decreased perfusion, that region of the kidney, remember the renal artery starts at the hilus and goes out, that region is particularly sensitive to hypoxic injury. The proximal tubular cells will die. We frequently see glucoseuria without hyperglycemia when we have AKI, and we'll have flooding of the distal nephron with too much chloride and sodium. So the appropriate response is actually local production of renin, afferent vasoconstriction, turn that glomerulus off, urine production will go down, and the appropriate response should be an oligoanuric state. And in fact, when we don't have that, when we have a polyuric state associated with acute kidney injury, it means that the macula densa, the juxtaglomerular apparatus, has failed. And in fact, the polyuric AKI represents a more severe injury because it's failure of both the proximal and the distal nephron, and is actually the worst of a physiologic injury than an anuric AKI. And to me, that blows my mind. Now, that's not the same thing as saying you have an AKI that's anuric because you have a post-nephron obstruction, or you are anuric because all your tubules are obstructed with cast and there's no flow. But that is something that I just thought was really awesome. I just thought that was a revolutionary way of looking at it, but it's just the basic physiology that is there in the kidney. So hopefully that's answering and providing some additional light to that concept. When the tubular fluid sodium chloride concentration is increased, renin activity increases. But remember, that's local. When we have decreased GFR and we have a lower concentration of chloride in the macula densa, we do have the increased renin release, but that is systemic. So we get systemic activation of the RAS. And I think it is confusing and interesting how the same hormones are involved to cause two very different mechanisms. Whether they're local, you're going to shut down that nephron, you're going to decrease GFR. If they're systemic, you're going to have predominant vasoconstriction of the efferent arteriole, increased capillary hydrostatic pressure, increased GFR so that you can pull out more sodium and water when we have decreased perfusion. So to me, I thought that that was really interesting. There's some data to suggest that our fluid therapy might mess around with this. And in healthy people, if you give a healthy person a liter of plasma light versus a liter of saline, it's been shown that the healthy people receiving the liter of saline have a 20 to 40% reduction in their renal perfusion. And it was presumed that it was from this mechanism, that they're having decreased blood flow because of that local vasoconstriction. And subsequently, there have been observational studies showing in critically ill people, if you give them a chloride-restricted fluid, such as LRS or plasma light, comparing that to people who received sodium chloride as fluids, there were better outcomes seen in those patients that received a fluid that contained less chloride, likely from this mechanism. Now, in larger studies, they have failed to show that, but they haven't shown better survival with the higher chloride containing fluid. They just have failed to show some of those benefits. So the concept of what fluid is best is still really not fully understood in people, and we certainly haven't evaluated that at all in our patients. But it's certainly something to worry about when our fluid therapy can provide 15 to 25 times the amount of chloride that the patient should be receiving a day as a maintenance fluid rate. We probably need to be thinking about giving hypotonic maintenance fluids way more often than I know I do, as a way to stop slamming the macula densa with all that extra chloride. So I hope that helped explain that concept, because it is, I think, very.
Thank you. I hope that my microphone is fixed. It is super helpful.
Yeah.
Thanks for a clear explanation. I think that what I was missing is that the renin's effects in the systemic versus the local release has a different effect. So that blew my mind.
Yeah, me too. When I read this, I was just like, wait a second, what? That little difference, it's just completely different physiologic responses.
And if you don't mind, I just had a follow-up question about still the tubular glomerular feedback. Because with that increased GFR or increased tubular flow to the distal, that works on eventually swelling of the cells in the macula densa, that utilize ATP, increase amount of adenosine, that eventually also sends the signals to increase ionized calcium that cause afferent arterial vasoconstriction. Am I understanding correct?
Yeah, and so that's one mechanism that people have suggested, that maybe giving something like diltiazem might be helpful, and that maybe diltiazem would be an effective therapy as a intracellular calcium channel blocker to be able to stop that vasoconstriction and maybe get increased urine production in some of these patients who had a relative oliguria or anuria. That's not really panned out in human medicine. In veterinary medicine, there's the infamous lepto paper, which I think is a garbage paper. Number one, was not statistically significant. Number two, and number three, people still cite it as a justification to use diltiazem despite not being statistically significant. But that's the only naturally occurring AKI paper that I'm aware of for the use of diltiazem, but even other therapies have not really panned out to try to impact that mechanism in terms of human medicine to facilitate urine production.
Perfect, thank you. And because I think the one thing that I was confused before I hear your explanation is that the adenosine also sends a signal that inhibits the release of renin from juxtaglomerular cells. So it seems to be then, is that then if there's a local increase or local release of renin at the same time, the other part of that system seems to be inhibiting the release of renin? Is that kind of like more maybe complicated than what I was thinking?
Well, I think it's probably two conflicting feedback loops. And you probably have the sensory apparatus of the macula densa saying, release more renin, and then the aberration in adenosine saying, wait a second, back off, we have too much. But I think unless you see an increase in unless the intraluminal chloride concentration normalizes, the macula densa is not going to let off that local production of renin, and I think it's going to win. So I think it's just a defense mechanism that's there, but is the lesser of the two.
Gotcha. That makes a lot of sense. Thanks so much.
Yeah, of course. So I know we're at the end of the hour, and I think that was really the main thing that this paper talks about, that mechanism is a way to stave off that life-threatening dehydration that's going to occur in that polyuric state. And maybe these patients who have oligo or anuric AKI, maybe they don't have a worse prognosis if we give them enough time. The problem is, and what's been shown in our patients, that oligoanuric AKI those patients have a 15 to 20 time higher mortality rate. Why? Because vets still give them way too much fluids and they become overhydrated. They become hyperkalemic, and that can be challenging to manage, or they need dialysis to manage them, and that isn't available or not affordable. So it makes them more challenging to manage in that state. But that doesn't mean if managed, they don't necessarily have the opportunity to heal and recover. And we see that all the time with our lepto patients that are anuric that will start making urine. We see it with our lily and grape toxicities that they're frequently anuric and they'll produce urine, give them enough time. So it's maybe not that oligoanuric states are a worse injury. They're just more complicated to manage, even though the kidneys are trying to help save themselves. It puts them in a state that if we don't recognize it, we can cause additional problems. By giving them fluids while they're not making urine, they can't get rid of it. So we're going to lead to increased risk of edema and ascites and hypertension, and we have to deal with the hyperkalemia. And luckily we have some additional tools to deal with that other than dialysis, but it does make it more complex. The polyuric patient is easier to manage, but in fact could be a worse injury to the kidneys, which I thought was really cool. Okay, that was me being really pumped for a while. Any other questions or comments or areas that were exciting or confusing that we didn't get a chance to chat about? Everyone feels comfortable that this system is like a finger in the dike until tubular function is reestablished. So many great quotes from this paper. So good. Love it. Okay, well, hopefully this was a nice follow-up session to the last one where we were talking about renal sodium handling. This is a little bit about urine output. I'll put together the papers for the next session, but we should basically be having it next month. I think we're all on track for that. The registration for this session I think is good for the rest of the year, but I'll send the registration link out as well with the papers to everybody. Let me know if you have any questions. Thanks for coming. Always good to see everybody. And I will chat with you guys again in about a month.
Thank you.
See you guys. Have a good one.
I think it's a brand of